Hi everybody, I'm Dr. Aditya Sethi. I'm going to talk about corneal tear management, an emergency that we all face in our emergency departments, and it's very important to know the know-hows. So why is it an emergency? We know corneal tear comes with devastating complications because the normal rules of anatomy don't apply. There's a risk of microbial entry with the opening. Hypotony leads to retinal issues, and if it's shallow or flat anterior chamber, it can lead to glaucoma and pars formations later. Etiologies, it could either be extrinsic, intrinsic, or conditions which are already affecting the ocular surface defenses. Even with a microtrauma can cause a corneal tear injury. Extrinsic, most common that we see is foreign body or a trauma that happens and comes to our emergency. So it could be either partial thickness or full thickness, and both need separate treatments. So it's very important to know which one. So how do we get to know? By doing a preliminary examination. First thing foremost, these are trauma cases, so you have to check them from the head to toe, not just the eye. So do a good physical examination, do color vision, visual acuity and IOP if it's not a full thickness trauma. Do a slit lamp or torch examination, look for signs of some conjunctival hemorrhage, limbal involvement suggesting scleral lacerations. If there's iris transillumination, think of an IOFB. There can be cataract, there can also be fibrin. Do a Siegel's test, which basically suggests if there's aqueous leak from these wounds. You can even call for a CT scan if you're suspecting an intraocular foreign body. Do a gentle B scan. This is a tip I would suggest for everybody because often the IOFB can be picked up by a B scan, and also retinal detachment and choroidal detachment can be looked at. Document, because these are all RTAs. You later need these documentation, very important for an MLC. And tetanus prophylaxis and oral IV antibiotics can be started. Corneal tear can be divided, the treatment can be divided into partial or full thickness. The partial, often just a pressure patch or a bandage contact lens is sufficient. If required, you can even take some sutures because, like we say, a stitch at time saves 9. Full thickness, if it's self-sealing, even a BCL is good. If it's a small laceration, if you think you can just glue it with a fibrin glue and put a BCL and later do a suture, that's fine. If it's mid to large, you have to take sutures. And if there's tissue loss, you can think of a patch graft or a PK. And if it's irreparable, even primary enucleation is an option. So non-surgical management include for a small well or post-corneal laceration, go ahead and do a pressure patch, put a BCL, that's another. Aqueous suppressant is very important to do that because you want to prevent any expulsives. Topical antibiotics and steroids to prevent infections and look after the reaction, and tissue adhesives can be used. Surgical management is most important. Use general anesthesia or subtenons, do not give a block. IV mannitol, which are aqueous suppressants, so that there's no expulsives. Don't put betadine because it'll go right into the eye and that can cause reactions. When you're draping, make sure that your speculum is not very tight. You don't want the expulsive again. Culture the wound. This is another tip that I can suggest, that culture it now because later if there's an infection, this will be easy for you to fight it. Secure the limbus first, or you can use temporary sutures also. Once that is there, then it's easy for you to put viscoelastics, do a nice paracentesis, and then go ahead and do your suturing. Maintain the AC always. Don't let it shallow for long. Use BSS or a high density viscoelastic. Avoid suturing the iris to the wound. Suturing, always form the AC, maintain the AC. You can use the air bubble or viscoelastic, whatever is suitable for you. Whenever you're pushing the visco, make sure you do it from the paracentesis and not from the wound. Even though in the beginning you can start with pushing a little bit in the wound, and once it's formed a little bit, it'll be easier to do paracentesis, otherwise it gets very difficult to enter. 10-0 nylon monofilament is the one we use. Always do a 90-95% depth, not a full thickness, not a partial thickness. I'll explain why. And always simply progress from the sides and then come to the center. And 1.5 millimeter in length, it should be your suture length, and always equal on both the sides to the wound. So this is how suture should look like when you're doing 95% depth sutures with the needle perpendicular. If you do a partial thickness, you always leave a small area which is not sutured, and that can be sinus for infection. If you do a very tight suture, you can cause another sinus on the top, and a very loose suture can cause a clumping of the margins, which can again be a sinus for infection. And if it's a full thickness, now the suture tract can get infected and cause intraocular infection. So you have to be very careful that you don't do a full thickness. So suture bites near the visual axis, make them shorter because that's where you don't want to interrupt the vision, and make a needle perpendicular while inserting 90% of that, and do not forget to bury the knot. This is one of the commonest causes of infections, that we forget to bury the knot, later the patient rubs and that leads to infection. This is how the suturing should be done, and this is how you bury the knot. So this is how your suture should look, equal in length, 1.5 millimeters, and perpendicular to each other, and parallel to each other. Principles of management. This is the most important slide I can suggest. This is in summary. It depends on size, etiology, and location. Provide stromal support, form anterior chamber, heal the wound, and prevent secondary infection by putting intraocular antibiotics. And always address the cause. Do not leave the foreign body inside. Do not leave the loose cortex inside. So address the cause as well. So this is a case where you can see a large tear right there. And what we did was so difficult to do paracentesis. So you formed with a little bit of visco, went ahead and did the paracentesis, took some temporary sutures, and later on sutured the entire part, buried the knots, and finally we were able to achieve some sort of normal architecture. So further reading, these are the various articles and chapters I can suggest. Thank you for your patient learning. I hope that I was able to impart some knowledge. Thank you.